present the next speaker, Professor Thierry Gevaert. I apologize if I mispronounced his name. He is a professor from Belgium, radiation oncology at the Free University of Brussels, and he's the coordinator of medical physics radiotherapy department at the University Hospital of Brussels. So I'd like to thank him for participating. Please go ahead.
First of all, thank you for inviting me to give that presentation regarding our experience for brain and motion management with ExacTrac Dynamic. Unfortunately, I cannot be there with you. I hope next time I will be able to join, but I hope you will enjoy the talk. So first of all, regarding our institution itself, first of all, we want to deliver quality education and research. We are a university hospital. And so what we mainly want to do is to look about the patient itself. And from there, we want to go into the most modern radiation techniques and biology concepts. So we have also a radiation lab. So we try to do everything in order that we can have the patient-tailored treatments. When you look about our patient population, you can see that we treat brain, spine, lung, breasts, and also abdominal cases. So we need a diversity of machines. So as I mentioned, we are multi-vendor. So we really want to look about what is needed for the patient and from there move ahead. And that's why we end up with 3 true beams with ExacTrac Dynamic on it, 1 Halcyon, 1 Radixact. And for abdominal cases, as we want to perform stereotactic treatments in a markerless way, so visualize the lesion and then treat, we decided to go for an MR Linac. So that's a bit the machine park. And we believe right now that with that machine park, we can go for stereotactic treatments. We can go for less fractions, higher dose, and minimalize the toxicity as well. So that's a bit the concept. Today, I was asked to speak a little bit about ExacTrac itself. So we are early adopters. We started in 2000 with it, with the very early versions where we were using infrared markers on the patient with an infrared camera. And then in 2020, things started to be more interesting as we were also able to use the surface guidance. And for that, what is surface guidance itself? So we are, in 2007, we started to do all kind of image guidance to position our patients. As I mentioned, we want to go for less fractions and higher up the dose while having minimum of toxicity. So the surface guidance for us, it's something that you have to add into your daily workflow and to see whether or not you can use it on a daily routine or where can it add some value. But I will show directly that we believe also that image guidance is still important. So what is the idea, the concept? So it's 1 camera. We like the concept of 1 camera because independently of the couch or the gantry, you can always take the surface and have a visualization out of it. And the information is surface, so purely visible light, that is structural light on the patient, and also thermal signature. It's doing a registration of those 2 information in order that he knows exactly where the patient is located into space. And then you can add the X-ray images, so anatomical information whenever you want during the treatment. And so that's a bit the concept. As you can see on the left, you have the 4D information, so the surface of our patient. And then on the right, you have the image guidance, so X-rays, and you can do triggering at certain gantry angles. You can do surface. When the surface is going out of tolerance, you can take images to see if the anatomy is also out of tolerance, or you can trigger it purely on monitor unit space. So that's a bit the concept. And as I mentioned, on our true beams, what we do is we do full ExacTrac for brain and spine. We do motion management for breast, and then the other ones, we just do surface-only workflow. So we just watch and see whether or not our patient is moving. I will focus on brain and breast today because I think it's the 2 most interesting parts to show a bit what we are doing with that concept. So regarding brain, we have a philosophy into our department not to go for all brain radiotherapy anymore, but to try to do an approach where we treat only the lesions. So we do stereotactic radiosurgery up to 15 lesions in a single fraction. And so that's a bit our concept. And so that's why also, yeah, as you can see on those images, yeah, you treat a lot of lesions. Of course, it's just on the screen that you see the lesions. So you need to watch out and be sure that everything is also at the right spot during the treatment. And that's a bit my talk today. How do we manage also to what you see on the screen is also what the patient will get at the end of the treatment. So we published already in the past that we can achieve sub-millimeter and sub-degree positioning accuracy. So about positioning itself, we know we are quite safe and we know that we can reproduce the dose at the right spot. But the question started to see, yeah, during treatment, even though for brain cases, patients are into a mask, the question remains, yeah, how do we cope that patient maybe can move in that mask? And as we treat multiple lesions as well, yeah, if in multiple lesions fashion patient is moving, yeah, it will have a lot of impact also on our dosimetry and also on the dose that we will deliver to the healthy brain as well. And so on the right, you can see if you only take images at the end of treatment just to see whether or not your patient was moving, you see that, yeah, you are submillimetric in the mean 3D, but you see that you will have some kind of standard deviation. So some patients will be out of the 1 millimeter. So we decided for that philosophical way that you need to add a PTV margin of 2 millimeters. So that's what we do for fractionated schemes. So if the lesion is too big, we go for a 5 fraction scheme, 5 times 7, so 35 gray in total. And so then we add a 2 millimeter margin because we fractionate. If we go for a radiosurgery way, so a single fraction, then what we try to study is what is happening if after each cartridge rotation, if we apply X-ray images, can it afford that we can go back to a smaller PTV margin? And we showed and published that we can go back to a 0 millimeter margin strategy. So at that moment, it was in 2013, we decided to, after each cartridge rotation, so for the non-coplanar arcs, we were applying X-ray images in order to reposition our patients. And then you can see standard deviation, it's much lower compared to the right image. And so that's showing that, yeah, you can have everything better under control. Of course, as I mentioned, we treat now multiple lesions. So you see it's a lot of lesions a bit spread over the brain. And you have publications showing that lesion to distance, so to the isocenter, the volume of the lesion can play a role in order that you need to add again a margin in order to cope for all those uncertainties. So this is how we treat it. This is how we treat. And again, as we were following literature, what we were looking at is that for multiple brain mets, we were adding back a 1 or 2 millimeter margin. So that's a bit the idea that we had in mind. So for multiple brain lesions, we go to 1 or 2 millimeter regarding of the volume, and for single lesions, 0 millimeter. Our department published already, because yeah, you can. I'm speaking now about 1 or 2 millimeter. Is that a lot or not? Well, our department published in the past that when you look about the peel of the orange and you take the peel separately from the orange, when you take that volume, well, it's only also a few millimeters, but you can see that the volume is more exactly the same as the orange itself. So each millimeter will affect also the amount of volume that you will treat. So that's why we are chasing about reducing those margins. And the group of UCLA, so the group of Nijde, was publishing as well that if you add 1 or 2 millimeter margin, it's not only the high dose that will be affected, but you will also see that the healthy brain, where the V5, 10, and 12 gray, for example, are important for radionecrosis, you see that also those volumes will be higher. So it's not only purely on volume, but also on the low dose spread within the brain that it will be affected. So my head of department doesn't like that. So we were looking into a solution. So with ExacTrac Dynamic, as I mentioned, when the gantry is at a certain angle, you can also trigger images. As you can see now, images are appearing. So on the right, you have still the surface guidance information, but I have also anatomical information. So I can use the skull to see whether or not my patient is well aligned. And this information is during treatment. So it's not like the previous slides I was showing that we only take images at the end of each arc and when the couch is moving. Now we can also take images during the treatment. And when you look about the box plot, it's something that we published in the Green Journal this year. So the blue ones, it's when you wait every time that you do a couch kick that you will again at some X-ray images. And when we do information during the treatment by applying X-ray images during the treatment, you see those are the red box plots. And the red ones, you see that you are really submillimetric. So one of my colleagues was reproducing all those uncertainties into the dose to see whether or not it will be affected. And we decided that if we go to a strategy, even though we go for 15 lesions, if we go for a strategy that if the surface guy go out of tolerance, like you see, like you can see the red peak, or the images, the X-ray images going out of tolerance during treatment, we do a beam hold, so the linac stops, we reshift our patients, so we apply the shift about what we are seeing, and we continue the treatment. We decided that we can go back to a 0 millimeter margin strategy. As I mentioned, we do a lot of stereotactic radiosurgery into our department because we do functional treatments, we do benign lesions like schwannoma, meningiomas. So for us, it's really important, because our neurosurgeons are also looking at it, that we are as precise as possible and that we can reduce those margins. So with that strategy that I'm showing, we believe that we can go back to a 0 millimeter strategy and that we are sure about the dose that will be deposited to our patients. We just started, but I just wanted to show, so for spine radiosurgery, so we do go for 24 gray in 2 fractions. We just started, but we also apply that kind of strategy, that we apply motion management with the surface, but we also apply X-ray images to see whether or not our patient is at the right spot. So that's a bit the idea. Then secondly, just to show you can also use a system not only for brain and spine. So as I mentioned, what I'm showing right now, it's something from, I'm started in 2007 in the department. From there, I was used to use those kind of images. So for us, it's like, that's our history that I'm showing and the evolutions. For breast, it's really something new. It's a new concept. So we all know that radiotherapy, there are benefits of applying a radiotherapy for breast cancer. The most important part is the risk of lung cancer induction and cardiovascular mortality. So we have to find a threshold between the dose that we want to deliver to the breast and the dose that we find acceptable to the lungs and the heart. You have publications showing that the mean heart dose is important. So the 4 gray is important for cardiotoxicity. So we try to avoid it or reduce it. And for the lungs, it's exactly the same. So the cancer mortality, the excessive risk model, it's depending on a mean lung dose. I'm not saying it's the way to go. There are better modeling, but I just wanted to point out that the low dose spread is important in order to avoid those kind of mortalities. And so one of the solutions is the easiest one, is that we coach our patients to take a deep breath, like we can see on the right CT scan. And from there, the air is pushing the heart and the thoracic wall from each other. And you see that you have suddenly much more space, which will make our life much easier to give a high dose to the breast while avoiding the heart, for example, in that image. And you can also see purely on the symmetrical way, you can also see that the dose the 2 left images are when you don't do a breath hold. So you see that there is high dose that will touch the heart. The 2 right images, you see that just by applying a breath hold, so just by coaching your patient, you can already easily avoid the dose to the heart. So that's a bit the concept. And why is that important? We in Belgium, we decided to change a little bit our fractionation scheme just by following the literature, of course. So in the past, it was 2 gray in 25 fractions, and we go to 15 fractions, 40 gray in 15 fractions. And now for some patients, we go to 26-31 gray in 5 fractions. And so what does it mean? We higher up the dose, so more dose per fractions, which means that the time that patients are laying on the couch will be higher, which means that we will also need to have more breath holds during the treatment in order to cope also for all those uncertainties. More times patients need to do breath holds. It's the fact that they will get tired, or they can get annoyed as well. And so there is a chance there will be a drift. So we have to watch out. And that's something we already have some data about it. So you can see the x-axis is the amount of monitor units delivered. The ETD is the ExacTrac surface. You can see that the amount of Bretholz the patient is performing, the bigger the chance that he will start to move. And that's something we know. So time is really precious, because the longer they are staying, the more they can start to move. And so that's also directly in translation. If you see that patient is moving, it means that you will also have to higher up your margins. And so which means also that you will have to deliver more dose to the lungs and maybe also to the heart. And so we believe, and yeah, we were looking into that, that maybe by applying some kind of surface guidance and some kind of tolerances, we can reduce again our margins, and to have also our patient better under control for Bretholz radiotherapy. So in 2022, we installed the Deep Inspiration Bretholz module, which is a kind of upgrade that we were getting in order that we can apply it. And this was our strategy in our department. So, or either we go for 15 fractions, so with a simultaneous integrated boost, or we go for a 5 fraction scheme. We treat left-sided breast always in Bretholz if possible. And the idea is that we take a free breathing CT and a Bretholz CT in order that we can see whether or not there is a benefit of applying a Bretholz to that typical patient. For the moment, we do pre-positioning based on tattoo points, we do a CBCT, and we do portal images at the first fraction, and then we deliver it, of course, in a Bretholz. And this is the things that when we installed the new version of ExacTrac, we wanted to see whether or not there is something we can add or something we can change in order that we have something better for our patients. Why do we look into that? Because together with my head of department, we are also looking into the pre-op scheme, so that we, instead of doing radiotherapy after surgery, that we have also some pre-op schemes in 5 fractions. And unfortunately, we had to stop that phase 2 trial because of the effect of toxicity. So now we are looking and reevaluating by having more precise treatments and more guidance during treatment. Can we go back to that kind of pre-op scheme in order to deliver a high dose to our patients? And I'm not saying anything new regarding surface and image guidance. So we have publications for breast cancer that are showing that if you apply surface guidance together with image guidance, you can have a decrease in margins because you are more accurate. So that's something we keep in mind. We know it's happening. And these are the 4 points that we want to evaluate whether or not we can have some added value by having the ExacTrac into our department. Surface guidance, so not only the ExacTrac, but all kind of surface guidance, we know that we can go to a tattoo-free workflow. What does it mean? Is it important? Well, applying tattoo points for positioning, the only problem for me is the emotional burden of our patients. They will always see those tattoo points, they see the lines sometimes on their skin, and that's something emotionally in the weekends and so on, they always are thinking back about what they are doing at the radiotherapy site. And so that's also why we were looking into it. Can we get rid of that? Efficiency. So with surface guidance, you can go with the patient in the treatment room. You align him or her on the treatment couch. You go out to take imaging, and that's more or less on average 3 minutes. So I think you can really efficiently position your patient. And then that's really the step that we wanted to look into it. Do we still need those laser and skin marks, or can we go to a fancy surface guidance positioning? And so that is what is happening in reality. So when it's red, it means that it's not within tolerance aligned. So what the RTTs and the nurses are doing, so they are moving a little bit the patient, they are sending the shift and so on, in order that they are pre-positioning the patient as accurate as possible at isocenter. So now they were placing the arms above the head. Now they will push the send shift button to move the couch automatically to the isocenter. And then you will see everything is green, means that we are pre-positioning wise at the right spot. I say pre-positioning wise, and I'm not saying anything new. You have publications showing that surface guidance is possible to do pre-positioning, so you can get rid of those tattoo points. But why is it only pre-positioning? Because we were doing a study. Even though you do surface guidance or tattoo point positioning, you see that you have residual errors. So you still need to apply some kind of shifts purely based on the anatomy. So we believe that you can do tattoo positioning, but if you want to reduce the margins as much as possible, you also need to address the uncertainties with imaging so that you have anatomical information during the treatment in order to cope for it and to act and be as accurate as possible. So we believe tattoo-less workflow is possible. Then the next step was, we have a new workflow. We were used to go for gated cone-beam CT on the left. So you have volumetric imaging, you see the tumor or you see the clips when the tumor is not there anymore. And so you can apply simultaneous integrated boost easily because you know you are at the right spot. With the ExacTrac dynamic itself, it's with X-rays. So you have to have some kind of other view. So you have to use the thoracic wall and to see whether or not you are at the right spot. I will now guide you through the workflow itself because I think it's quite interesting. So as I mentioned, at simulation, we are applying a breath-hold CT and a free breathing CT. So the purple pink one is the free breathing CT and the yellow one is the breath-hold CT. So we are adding the skin contours of those both. And the system now can evaluate wherever we want to evaluate it, what is the amplitude of the breath holds. So, and then he will guide, I will show you later on, he will guide you directly also our patients in order that we can accurately position, but we can also accurately guide the patient to re-perform the same breath hold than was performed at the simulation site. So you see now the cross moving. This means that it's the point of respiration that we want to evaluate during the treatment. So now you see that the free breathing is acquired, and now you see a gating window applying, and that gating window is basically where we want the patient to perform the breath hold. So that's a bit the concept. And how do we guide our patient always at the right spot? Well, it's with on the right, you see a blue ball and you see a circle. So the patient is seeing that and she knows that where she needs to perform the breath hold within the circle in order to have an adequate breath hold during the treatment. And then once the patient is performing breath hold, on the left, you see also the respiratory cycle. You apply X-ray images. And then the fun part starts, it's performing the the registration, sorry. So the red parts that you can see on the images, those are the parts that you don't want the system to apply registration on. So the vertebrae, the clavicula, the arm and so on, those are mobile structures, so you don't know if they are the right spot. So what we are interested in is really the thoracic wall, because this is the part that we know that needs to be at the right spot in order to be sure that the breast is also at the right spot. And then you can also transpose the structures like the lungs onto those images in order to see whether or not the lungs are within the thoracic wall. So you have also an organ at risk verification. And so, before applying that kind of new strategy into our department, we wanted to see whether or not we can evaluate it, but we can also validate it. And that's why we were doing 7 fractions with a cone-beam CT, so with volumetric imaging, and then just applying a verification with X-rays to see whether or not they are in accordance. And then we were doing the other way around for the 7 other fractions by applying X-ray imaging and verifying it with a CBCT. It's just a validation scenario into our department. And these are the residual errors that you can see and that we managed to have after those kind of study. And you see whether or not you apply X-rays or CBCT, you see that the residual errors are exactly the same, which means that if you go for volumetric images or X-ray imaging, I think at the end, it's the same. You have just other information that you have to understand and to evaluate in order to position your patient, but we believe that it's exactly the same. So that's our vision. And then why I'm showing APIT images, by law in Belgium, the first fraction, we have still to apply APIT imaging in order to see the treatment field. So these are the images that we are getting. But I think, because I know, we are an image guidance center, but I think sometimes it's overshooting by applying all the time cone-beam CTs or X-ray images. I think for the centers that likes and applying already APIT images for breast cancer, I think here, when you see that kind of portal imaging, you have only 2D information of whether or not your patient is well aligned. Purely visually, I think it's quite in accordance with the X-ray imaging that we are doing with the cystoscopic X-rays that we can do with ExacTrac. So I think it can be interesting for the centers that have already APIT images at their treatment site, that the X-ray images will add some value, because then you have 6 degrees of freedom information. So if there is a rotation, you can also get rid of it. So I think that's something ExacTrac and the stereoscopic X-rays more deeply. There are something in between what you can apply with a co-beam CT, and you have more information available than those APIT images. So that's a bit our vision or our idea. And that's the most important part, because once your patient is well positioned, you want to treat the patient. The important part is now, are the breath-hold always at the right spot, and are the breath-hold stable? Because if it's not the case, the heart can be positioned whenever where the patient is performing the breath-holds. And so, as I mentioned, the alignment is purely based on simulation. So it's on the contour of the free breathing and on the contour of the breath-holds. And so with that information, the system calculates all the time where the patient needs to hold the breath. And we see that with the new device, because it uses information from the past, so from simulation and from dosimetrical information, you see that the uncertainty and the reproducibility, it's much smaller now. So that's something for us, it's also important. We see that we are within a tolerance of 4 millimeters, that the patient is reproducing those breath-holds. And again, why is that important? Well, if you have a dosimetry that you see you visualize together the dose, you see, oh, okay, no dose to the heart, very nice. If the patient is not reproducing that breath-hold at the time of treatment, you see that the heart can be at another position, and maybe the dose will be delivered to the heart and not against the heart. So that's something, the breath-hold stability is really important, and that's something also for us, we saw that's something new, and that we can add also some new information, and that we can move ahead to have patient-tailored treatments. And then, of course, intrafraction motion, as I mentioned again. So patient is seeing the blue circle during the treatment. He knows he has to hold the breath within the circle. We are seeing the breath-hold, the breathing pattern of our patients. We have surface information, but we have also X-ray imaging during treatment. So you can take images whenever you want. So again, you have surface surveillance, but you have also anatomical information to see whether or not your patient is at the right spot. And so that's something we believe. You don't need to take always X-rays. You can also just do surface surveillance, but that's something that is adding some value if you want to go like we are doing, like pre-op schemes, or you want to do some new phase 2 trials. Last but not least, and then I'm finished. What we are doing as research, I just wanted to show a little bit also that, as we are a university hospital, we also are doing some research. So what about lungs? So we are having some troubles when the lesion is moving more than 15 millimeters, what to do with it. So we have some kind of IDs, gating, breath-hold, and so on. So we like to have those kind of IDs. Our only problem is that patient can drift. We have a long time history about motion management, and we know that patient can drift. Patient or lung patients, they sometimes have problems to hold their breath and so on. So we know that they can drift during the treatment. So we need to have a solution in order we can also analyze whether or not during treatment we can see the lesion and we can continue treating. That is why we are looking now, it's purely research, it's not a commercial product yet. So we are using the surface information on the right, and we take X-ray images on the left in order that we can try to visualize the lesion. And that's purely R&D. We had a poster this year at ESTRO. This is something R&D with BrainLab that we are doing right now, is to try to visualize the lesion, as you can see on those images, and to try to track the lesion in those X-rays in order that whether or not patient is having another breathing pattern, we can see whether or not we are hitting the target. So that's something also new. That's something we can do with the X-rays, and that we believe that it can be a next step into have, again, those kind of patient-tailored treatments. So in conclusions, I think the surface guidance, we all know it can add the tattoo-free workflow. Emotional burden of our patients, it's important. We believe that imaging is still important, so we like to have surface surveillance, so we see the surface, but when surface goes out of tolerance, we like to have kind of imaging, anatomical information to see whether or not we need to adapt our patient positioning. Regarding brittle stability, well, the system is purpose-built and made in order to reproduce and to have brittles stay in a stable way. So we believe that's also the way to go. And again, during treatment, you can decide, do I go with surface? Do I go with X-ray imaging? So I think it's an added benefit to have the both systems in order that you can play with it and have your own vision and philosophical way how to apply those kind of information during the treatment. I thank you for your attention.
No room for questions for this session, unfortunately, but lunch break is now ready. Please, we'll reconvene at 1 p.m. Thank you so much.